So our next speaker, I will just like to introduce Dr. Shilpa Das, and she's a consultant in Narayan Nethralaya in the Department of Cornea, Ocular Surface and Refractive Surgery. So she will be speaking on why lubricants don't work and the importance in dry eye. Thank you.
A very good morning to one and all. I am Dr. Shilpa Das from Narayan Nethralaya, Bangalore. Today I will be discussing a very commonly encountered entity in our day-to-day clinic, that is dry eye syndrome, and why in many times the lubricants do not work. Ocular lubricants are sterile, hypotonic or isotonic buffered solutions that replenish the tear film. But is dry eye a simple tear deficiency? No. It is a multifactorial disease of the ocular surface characterized by loss of homeostasis of the tear film instability, hyperosmolarity, and ocular surface inflammation. So not only the diagnosis of the dry eye but also treatment and monitoring the response of the patient to this treatment leads to eventual cure. Now, among the menu of treatments for dry eye disease, artificial tears, gels and ointments are at the top. And we look at general characteristics, effects, presence of preservatives, electrolyte composition, and osmolarity and viscosity agents present in these lubricating eye drops. They include drugs like polyvinyl alcohol, povidone, the carboxymethyl cellulose and hydroxypropyl methyl cellulose, the polyols, and the hyaluronic acid. Viscosity building agents such as carboxymethyl cellulose, hydroxypropyl guar, polyethylene glycol, and sodium hyaluronate augment the aqueous layer and transiently reduce the tear film osmolarity. Apart from these cellular derivatives and liquid polyols, we have dextrin and glycerin that increase mechanical strength as well as act as an osmoprotectant. Other osmoprotectant agents include trehalose and erythritol. Now, lipid-based eye drops. These are not so common in India, but we see them in the international market. They are amphiphilic lipids and surface stents that fortify the tear lipid layer to inhibit excessive evaporation, improve tear layer thickness, and reduce tear evaporation, resulting in superior prophylactic efficacy. So, these are very important in the MGD cases. So, which lubricant do I choose in my clinic? I have to decide the type of lubricant to use and the frequency for the patient. So for this I depend on many factors like the severity of dry eye, the kind of dry eye, tolerance to preservatives, cost factor, and lifestyle of the patient. Severity of dry eye we determine through many ways. First is the ocular surface disease index or other questionnaires like dry eye questionnaire, speed questionnaire. Symptoms of the patient we can classify from grade 1 to grade 4. Several tests in the clinic as well as diagnostic tests, the most common being TBUT, tear meniscus height, the staining pattern, Schirmer's test, tear osmolarity, molecular markers, and automated diagnostics like lipid layer interferometry and mebumin gland morphology. So once I know how severe the dry eye is, for more severe cases I will be using those that have a high residence time and high viscosity on the ocular surface. The type of dry eye, very important to distinguish which kind, whether it's aqueous deficient or evaporative. Aqueous deficient will require more of higher retention on the ocular surface and a very higher viscosity as well as those which are osmoprotectant, whereas evaporative dry eye will include something like a lipid containing eye drops. The most common entity we see in aqueous deficiency is a Sjogren's syndrome. Now here we know that for mild cases only artificial tear supplements may be enough. But for the moderate to severe cases, especially those with the associated connective tissue disorders, require topical as well as systemic corticosteroids as well as immunosuppressants. The non-responsive cases require additional therapy like lacrimal plugs, IPL therapy, autologous serum, and or scleral contact lenses. Another common entity, the mebumin gland dysfunction. Mild cases, warm compresses and antibiotic ointment would do. But for the non-responding and severe cases, we need to use additional oral antibiotics, additional topical anti-inflammatory, oral fatty acids, thermal pulsation therapy, and intense pulse light therapy. So in these situations, only lubricants are not enough. We need to address all these things. Tolerance to preservatives, a significant concern with long-term use is the presence of irritating preservatives which can compromise the ocular surface and worsen the patient discomfort. Earlier we had benzalkonium chloride, now we have shifted to polyquad and stabilized oxychlorocomplex which are less irritating. In the Indian scenario, cost factor is very, very important. I have seen many patients who seem the affording type, but then later on they say that they are not able to bear the recurring cost of lubricants, especially due to prolonged use. I went through some of the drugs and I see that the gels are more costly than the eye drops. This is in Indian rupees, and there is a positive steep when the range goes from the carboxymethylcellulose to the sodium hyaluronate. The lifestyle, very important. Even if we give a lot of lubricants to the patient and treat the dry eye, if the patient has a prolonged screen time, working in low humidity environments, especially late at night, or is a smoker or a chronic alcoholic, then your drugs will not work. So very important to address this. Now there was a very interesting paper published in 2014 by Dr. Moshirfar and group, a literature review of all the articles on dry eye and artificial tears published till that date, and they gave an algorithm saying that the initial treatment of dry eye, if it was mild, most of the authors used CMC and HPMC as well as sodium hyaluronate. If it was refractive, they would add the polyols, that is polyethylene glycol and propylene glycol. If the symptoms would persist, they would add gels, and ancillary options were ointments and liposomal sprays. So to conclude, what I look at while administering lubricants to patients would be the severity of dry eye, the type of dry eye, the response of the patient, compliance of the patient, the effect of the environment, and also mainly address the cause of the dry eye. Among the causes, address eyelid pathologies, address local and systemic inflammation, anatomical variations of the eyelids, nutritional deficiencies, and effect of external stimuli before saying that lubricants do not work. Thank you very much.
Thank you, Dr. Shilpa. Any questions for her?
I'll just ask one thing. Yeah. So, Dr. Shilpa, when do you suggest we investigate for secondary Sjogren's if they are not really responding to our treatment?
Mainly would be the systemic features of the patient rather than waiting to check whether the patient is responding to therapy. So it's basically history.
Okay.
History and your systemic evaluation, which you can ask whether the patient is having joint pain, skin disorders, or all apart from your regular diabetes and hypertension, which is more focused in ophthalmology compared to the other histories. And then also we can physically look for any deformities. Sometimes patient may not have, but then you may be the first one diagnosing. Otherwise, you start your treatment and not responding even for a month, or you see that the patient is having a dry skin, dry mouth, that's when I refer to a rheumatologist and start the systemic therapy.
And do you suggest starting the immunomodulators on your own or tapering, or always with a rheumatologist? What if we do not have one
the
in
systemic always with a rheumatologist, but I do have some patients who refuse to go or do not go. In that case, I start by myself.
Because the compliance will be a little low to a second doctor.
Correct, definitely, I agree. And based on experience, we know that HCQs and methotrexate are the most common drugs, and tapering dose of Vizorone. So you can initiate by yourself and monitor the blood parameters like CBC, LFT every 3 months.
And how often do you suggest to follow up?
Follow up depending on the grade of severity. 1 month for sure, and after that maybe every 3 months.
Sure. Thank you.